Good afternoon and welcome to this meeting of the Health and Wellbeing Board. I'd like to inform those present that this meeting is being webcast live and will be capable of repeated viewing. It may be worth explaining that voting members, including health partners, are in attendance in the chamber to take part in the debate and make decisions. Some officers and some partners may be joining the meeting via Microsoft Teams. So we'll just start with some procedural business. Are there any members in attendance as substitute today? No? Thank you. Are there any members are there any apologies? Oh, sorry, I have apologies from Stephen Marglin from the University Hospitals Sussex, Professor Robin Banerjee from the University of Sussex, Kate Pilcher from the Sussex Community Trust, and Ian Smith from NHS Surrey and Sussex. Ian is out of the country at the moment, but I'm pleased to say that he'll be joining us nonetheless remotely. Before I continue, are there any... no, he sent apologies, and that last bit was not true. So are there any declarations of interest? Do any members wish to declare any interest in relation to any matters included on the agenda? No? Thank you all. So we have no part 2 items today, so the press and public won't be excluded. So we move now to the minutes of the previous meeting. These were circulated with the report pack. Does the board agree to approve these minutes of the 3rd of March as a correct record? Are there any clarifications needed? Or corrections? No. Thank you. So I've just got some quick chair's comms to do, and then we'll move on with the substantive part of the meeting. So good afternoon, everyone, and welcome. Before I begin, I'd like to thank all the officers for the work that's gone into preparing today's meeting and the papers before us. As this is my first meeting as chair, I'm looking forward to working with everyone around the table. I've spent the last 30 years or more working in homeless services and other allied services, which has, if nothing else, reinforced for me how closely health, housing, social care and the voluntary sector are connected. It's also taught me that improving health outcomes depends on strong partnerships. I'll be using today's meeting to listen carefully to understand your perspectives on our key strategic challenges. And I'll think about how this board can make the greatest difference for the people of Brighton and Hove. I hope we can have an open, constructive discussion. Slightly at the risk of repeating myself, the keys to the success of this health and care partnership is the contribution of individuals and the leadership they bring. I wanted to acknowledge a couple of these individuals today. The first is Kay Duderoff, the CEO of the Trust for Developing Communities and chair of our East and Central Integrated Community Team leadership groups. Kay is retiring in September after spending at least 25 years of her working life serving our local communities through active community development. This work has had a huge and positive impact on our most underserved communities in the centre and east of the city. In the last couple of years, Kay has brought this experience to the development of our new integrated community teams, and she will be missed by local colleagues involved in neighbourhood health. Please join me in thanking Kay for all her hard work and service over the years and wishing her well for the future. And I also want to recognise the contribution of Tanya Brown-Griffith, Tanya, to this board and our wider healthcare partnership. Tanya has been our local ICB director for the past couple of years and has worked closely with you all in her active support of the work of this board and working particularly closely with my local authority colleagues to ensure there is a strong partnership between the local authority and the NHS. Tanya, I know colleagues will miss the experience and expertise you have brought to your role and will also join me in wishing you all the best for your new role in the ICB. We do appreciate the ICB's commitment to the work of this board and are pleased to welcome Ashley Scarf, who will be taking over Tanya's membership and responsibilities associated with this board. Welcome, Ashley. We have a busy agenda today. There's no need for me to tell you what's in the items as the presenters will make it clear. Just a couple of things to note. Firstly, we're going to move the employability and health item down the agenda so it's directly before the item on integrated care teams. There are important crossovers between these two items and we didn't want to lose that link. Secondly, you will see that Surrey and Sussex Integrated Needs Assessment is listed as an information item at the end of the agenda. I do urge you to read the INA. But it's just here today for information rather than discussion. I also wanted to bring members' attention to the launch of the first stage of the consultation on the development of the new city plan, the spatial planning strategy for Brighton and Hove. The quality of the built environment is really important factor in population health, and I would encourage all organisations sitting around the table today to engage with the council as we develop a new city plan. Details of the consultation were shared with the board members last week and will be circulated again following this meeting. So I'm now going to hand over to Giles for the call over.
Thank you. Can I ask that members indicate those items they wish reserved for discussion by calling them as appropriate? Item 7, Safeguarding Adults Board Annual Report. Item 8, Integrated Community Team Neighbourhood Plans. Item 9, Better Care Fund. Item 10, Employability and Health. And item 11, Health and Wellbeing Board Development Workshop Outcomes. I can confirm that all items have been called. Thank you.
Thank you, Giles. So we now move on to item 4 on the agenda, which is public involvement. We have a deputation at today's meeting from a local resident. The clerk will read it out and I will respond to it. Giles, you have 5 minutes to represent this deputation on behalf of the resident.
Thank you. Chairs, members of the board, the independent NHS investigation into Wellbeing identified actual and potential harm affecting children and young people in Brighton. It examined NHS primary care rather than Brighton and Hove City Council. We fully accept that distinction. However, safeguarding does not operate in organisational silos. Children move between schools, families, youth services, primary care, specialist services and social care. The Health and Wellbeing Board exists precisely because safeguarding and public health depend upon effective partnership working across those boundaries. The question, therefore, is not whether Brighton and Hove City Council was the subject of the investigation. The question is whether the investigation gives rise to any lessons for the Council's own safeguarding responsibilities. Good safeguarding practice requires organisations to learn from serious failings wherever they occur within the local system. It does not require an organisation to accept blame. It does require curiosity. Residents have therefore asked the straightforward governance question: has the Council considered whether any lessons arise for its own safeguarding arrangements, work with schools, external partnerships or commissioning relationships? Over recent months, residents have raised this question through correspondence with the Chief Executive, through the Health Overview and Scrutiny Committee, through the People Overview and Scrutiny Committee, and at full council. To date, the principal public response has been to emphasise that the Wellbeing investigation examined NHS services rather than council services. Whilst factually correct, that does not answer the question being asked. No resident has suggested that the council was the subject of the investigation. Rather, residents seek reassurance that the council has reflected on whether any aspect of its own policies, guidance, partnership working or safeguarding governance should now be reviewed in light of what has been established. This is particularly important because concerns about safeguarding, social transition, external providers and evidence standards have been raised publicly by parents and residents over a number of years. Some of those concerns were dismissed at the time. The Wellbeing investigation demonstrates why safeguarding systems should remain open to challenge and willing to examine uncomfortable questions. PCHE Brighton therefore asks the Health and Wellbeing Board: 1. What process has been undertaken to identify any organisational learning arising from the Wellbeing investigation for Brighton and Hove City Council and its safeguarding partners? And 2, if no such review has been undertaken, will the board now commission or support one? This is not a request to revisit political debates. It is a request to demonstrate the principles that underpin effective safeguarding: curiosity, transparency, partnership working and organisational learning. Public confidence is strengthened not when institutions insist that failures happened elsewhere, but when they show they are prepared to ask whether those failures reveal lessons for themselves.
Thank you, Giles. Thanks to the resident for that deputation, and here is the response that we have prepared for them. The Council is aware of the shortcomings identified in NHS England and NHS Surrey and Sussex Review. The Council's Health and Overview and Scrutiny Committee, also known as HOSC, is a correct forum for issues of primary care quality, and I understand that this issue will be considered for a future HOSC meeting. There is no evidence to suggest that there are systemic safeguarding failings within the Council, but as always, the Council is keen to hear from families directly should they have specific issues they would like to raise with us regarding their individual experiences. Is the Board happy to note this deputation? Thank you. It will be noted. Thanks again for that, Giles. So now we move on to item 5 on the agenda, which is member involvement. We have no member questions, so we will move on to item 6. And that is a presentation from Penny Telford and Ruth Davey about the Children and Young People Emotional Wellbeing Conference that I was happy to attend. So would you like to come and do that presentation now, Penny and Ruth?
Thank you, everyone. I'm here to talk about a childhood anxiety conference that we held on the 11th of June. We go to the next slide. So on the 11th of June, so very recently, 9 a.m. till 2 p.m, we held a conference on childhood anxiety. What started as an idea for a 2-hour workshop rapidly developed into something far bigger. It could have easily become a full-day event, but we managed to just about keep it condensed to that timescale. The reason that we did it was designed to really bring together people to answer some key questions. Those questions were, what can we do now to address anxiety amongst children aged 8 to 13? Secondly, how do we best intervene early, build resilience and help children understand anxiety? And thirdly, how can we reduce the number of teenagers seeking medical help for anxiety? In order to answer these 3 questions, we turned to several experts, both local and national. Those experts were our keynote speakers, Professor Robin Banerjee, who I know that will be familiar with many people here, gave a really interesting presentation on kindness, empathy and well-being and his research on those areas. Roisin McAvoy, who's the Head of Department Training and National Programmes for Anna Freud, became involved because of her interest in protective behaviours, which is an area of work that we deliver as part of our safety net programme that Ruth heads up. She presented her research in that area and the effectiveness of that. Dr. Adam Fazakali gave his perspective as a local GP. Mehmet Agdaran carried out a mapping exercise about all the provision that we have locally, which was really interesting, and I'll go into more detail later. Sarah Colombo delivered the results from the latest Safe and Well at School research. Lance Stan and Martin Spinelli run a comic called The Res, and they gave a really interesting interactive talk on that. Jen Tullock and Ruth spoke about their own work in schools as part of our safety net programme and youth work, and also brought in the voices of young people. I'll play a video later which brings that to life really nicely. Peter Dedman, who was the co-founder of Infinity Foods and now runs the Brighton Natural Health Centre, gave a really interesting talk on the link between food and mental and physical well-being. And Laura James, Head of Therapeutic Services at the YMCA Downsett Group, gave a really compelling and interesting story from one of their service users. As if to sort of illustrate how jam-packed the agenda was, we also held a workshop over lunchtime with grassroots suicide prevention. So why we did it? Childhood anxiety is rising, yet some of the most effective responses are already known. We believe that the challenge is not a lack of insight, but how we translate this evidence, lived experience and local practice into joint action that can be implemented and tested quickly and at scale. So the conference really focused on practical solutions, grounded in research, lived experience and real-world delivery from practitioners and leaders in the field. Impact Initiative's long-standing experience delivering work based on the protective behaviours approach meant that we were able to attract some leading figures such as the Anna Freud Centre, as well as other local experts bringing their own insight. The conference, as I said, was really well attended. What began as potentially much smaller grew to over 70 attendees. And we were really pleased to have attendees from Brighton and Hove City Council, local businesses, funders, GPs, NHS, local schools, university, and the voluntary sector. People worked collaboratively across the sectors, and it allowed them to share insight, listen to a new perspective, and make new contacts.
Excuse us, Giles is just trying to make a video play on PowerPoint. Penny and Ruth, I'm really sorry, but we don't have access to the video. It wasn't embedded, for whatever reason, into the PowerPoint presentation. So I'm afraid we're not going to be able to play it.
That's okay. I won't perform the video, but it was...
You can reenact the whole day if you want.
We can share later, hopefully. It's a lovely video which we filmed in West Batchington School of their mental health champions group, and they spoke about their own experiences of mental health. And also we filmed an older young person that attends one of our groups who gave the perspective of other group members. Hopefully you will have a chance to view it because it's a really enlightening video about their own perspectives of mental health and what that means to them. It also really grounded the day and made us understand why it was so important that we tackled some of the issues that we were talking about. Okay, what we learned. What we learned firstly was that there's a huge appetite for understanding and tackling childhood anxiety. As I've said, the event grew both in terms of the content and the attendees, underlining just how important the topic is. People really valued the chance to meet other experts from across other sectors. The feedback survey, somebody fed back, meeting other people, hearing insights from passionate people working in this field. And I felt that came across really strongly on the day. There's certainly demand for centralised information. There was lots of good work across Brighton and Hove, but people weren't aware of everything that was in place, and that really came through in the feedback as well. The next slide is just some more feedback in detail. Thank you. So yeah, the feedback was really positive, but it was quite consistent in terms of what we heard, and that included from people working in the NHS, local schools, local charity sector. They all really, the feedback was really consistent. Cool. Go back one slide. Thank you, Charles. So what's next? We're now forming small working groups to take forward the work. We heard loud and clear there's demand for a centralised point of all the available help, and we really want to focus on creating a connected system. We're already linking planning with older age group youth work. It's something that Impact are involved in working on for that transition age group for Brighton and Hove City Council, so that's really feeding into the planning. We're carrying out a mapping exercise with Mehmet's team, and that will be in August. So we gathered together lots of insight, and we'll be using all that information gathered to map it in far greater detail. We also have future sharing the space conferences planned, so bringing together the huge amount of expertise that exists in Brighton and Hove. It was really invaluable, so we really want to keep up the momentum.
Amazing. Thank you, Ruth, and thank you, Penny. I would like to thank you for inviting me to the conference. I really enjoyed it, and I can testify that the excitement in the room and the pleasure that people felt at being there was palpable. So it was a really excellent conference, and I'm really sorry I had to leave before the afternoon session because I think that would have been equally as great. Does anyone else have any questions for Penny and Ruth? Go ahead, Jess.
Hi, for those who don't know me, Jess Gibbons, Chief Executive here at the City Council, and thank you so much for that and sharing. It's really great to see, really inspiring stuff. And I guess for me, I'm just really interested in what you came away thinking are the sort of key themes that we as the City Council really need to hear from the conversations in the room.
Certainly. I mean, I think there's some really key themes. One is that people really valued prevention and early intervention. That came across in a lot of the research that we listened to, and we heard it loud and clear on the day as well. Secondly, that people were really keen for collaborative partnership working. I think the sentiment in the room was really strong that this isn't a problem that can be solved in silos. Everyone needs to work together. And actually, it was a real delight to see the amount of passion people have for working together to solve the problems. I think there was certainly a lot of passion as well for uncovering new ways of working. So things like the RES, for example, was really well received. Peter Dedman's talk on food and wellbeing was really well received. So yeah, examining new ways of working was really key as well. I don't know if you had anything to add to that.
No, I think some of the other discussions that came out were around transition points as well, which is something that I know that Brighton and Hove City Council is looking at this moment in time, and is something that we're working on actively.
Thank you, Jess. Thank you, Penny and Ruth. If there's no further... Oh, go ahead, Lucy.
Thank you, Chair, and thank you. It sounds amazing. I was just wondering, was there any work done, or is there any work being done thinking about timescales on delivering help for young people with mental health issues? As in my day job, I'm a teacher, and I know that we've had children in quite severe mental health crisis. That means that they're not actually able to attend school, but still they are waiting, you know, weeks, if not months, to access that mental health care. And I'm just wondering if part of your conference was anything to do with actually sort of timescales and how we can get in there when children are really suffering these severe mental health crises.
I'm not sure I'm that well placed to answer that question. I think one thing that may be of interest is that we heard the feedback that there is help out there, but people don't necessarily know what that help is and how to access it. So that's an action point that we've taken sort of immediately to make sure that we do broadcast what help there is available. I think in terms of waiting times, I don't know if we would have an answer for that. It could be something that we need to take away from.
I think I can't answer for Ruth and Penny, but I think the vibe of the conference, to use a horrible word, but I'll use it anyway, was more about those interventions that can be made before we get to the stage that we're looking at getting children to crisis intervention. So I think that wasn't, for me, a focus of what people were talking about. It was more to do with how can we diffuse the issue before it becomes that other issue that I think you're referring to, Lucy. Go ahead, Adam.
And also something that sort of was all throughout the conference was, you know, these children
often aren't ill within themselves. It's the sort of the social fabric that is wrong around them. And what we keep doing is healthcare. We've done it for 40 years now. Is people who are suffering with mental illness, they get treated with symptomatic relief, and that's just not working. Prevalence just keeps going up. So we need to start to understand the causes of what drives distress, and then work together as a health and wellbeing board, schools, and how we can actually address that together. And that is our responsibility, because if we don't do it, if we just keep doing the same thing, things will get worse. And Robin Banerjee talks a lot about the whole school approach, so how to engage the whole class as the solution, rather than thinking, oh, there's an ill child, let's resolve that issue. The issue's not normally bigger.
Yeah, no, absolutely agree.
Thanks, Ellen. Steve, and then Caroline, sorry.
Thank you, Chair. Steve Hook, Director of Adult Social Care. It was a great presentation. I'm particularly interested around your sort of work around the transition age group. I mean, we know, don't we, that since particularly the pandemic, childhood anxiety and particularly sort of adolescent anxiety has increased. And sort of 5 years on, we're now seeing those young people who were 15, 16, 17 coming into adult services. And this is a cohort of young people who 5, 10 years ago would never have come near needing kind of social care or psychological help. So there's something really important for me about how we link up with our transition strategy. We are appointing a programme manager who we hope to have in post by sort of mid-autumn. And your work around good information and advice, it chimes a lot with the work we're doing. So I'll make sure that we link in.
Thank you, Steve. Caroline.
Yeah, I was just going to say that so there is a lot of work going on, but it's just never enough with the older teenagers. And that's one of the reasons that we decided to focus on the younger age group, because whilst that's all being dealt with, if we can prevent the next tranche of young people when they get to that age being in need of such desperate help, then that's probably a good place for us to focus. And so that's what we built the conference around. I mean, I know through the UAK contract there's work for the children to adult services, and there's, you know, rafts of youth work and mental health support. And in school, via the school nurses, there's several organisations who, work with young people that are referred via that route, but it's just not enough to keep up with the demand.
Thank you, Karen. Thanks again, Penny and Ruth, and I hope when you drill down into the information you generated that day, you'll share it with us, and then I hope you invite me to any other events. So, cheers. Thank you very much.
Thank you. Thank you.
Bye-bye. Actually, I don't know why I said bye-bye then, excuse me. So that brings us to item 7 on the agenda, which is the Safeguarding Adults Board Annual Report. And Siona Douglas will be leading that. So thank you, Siona. Apologies, Shona, I mispronounced your name. Shona, could you use the microphone, or people at home can't hear you? Yes, at home. Where am I getting these photos?
Right hand back.
Is that better? Oh, yes, that is better. I always check those things first. Thank you. Thank you, Chair, for the introduction. Can I just, first of all, just check that members have had a copy of the annual report and the strategic plan in the papers? That's lovely. Thanks so much. Thank you very much for inviting me. I'm Shona Douglas. I'm the independent chair of the Adult Safeguarding Board, and it's my role today, and it's always a privilege to be here today to present to you the annual report of the work that's been undertaken at a strategic level by the Safeguarding Adults Board in this year.
And Chair, you started by talking about partnerships and around the importance of partnerships and how things happen through the partnerships. And I've done a fair amount of work throughout the country with a number of safeguarding adult boards, and I do chair other boards as well. And I probably should declare I chair East Sussex Safeguarding Board, which is next door. There are advantages to that, of course. But I would say to you that this is a good working partnership. And I think that's one of the key things to kind of say to you as members, because I'm here to present to you around, you know, I seek as a chair your help because you're the eyes and ears of the communities in which you serve. And so I think what I wanted to say was that I've chaired the board now for 3 years, and certainly I've seen the partnership grow and develop, and there's a good working relationship, and I think that's the foundation to how you start to build a successful partnership. But I will present to you today a little bit of the background and to highlight some of the points, not all of them in the report, but just to highlight some of the key points of the work that's been undertaken in the last year. So I guess it's just a kind of quite important place to start about what Safeguarding Adults Board's duties are. And actually there is a lot of national work focused on social care, and I'll talk a little bit about that at the end. But currently the legislation is governed by the Care Act 2014, and there are 3 distinct strategic roles, well, statutory roles of the function of the board. And the one is to present a strategic plan, which you have a copy of, and we've got a 3-year plan. The other is to present an annual report to you of the work that's been undertaken by the board. And the other is to commission and carry out safeguarding adults reviews, which commonly known, I hate acronyms, people know that, but they are referred to quite often as SARS, safeguarding adult reviews, of any cases which meet the criteria as outlined in section 44 of the Care Act, and I'll talk a little bit more detail about that further on in the report. But they're the 3 distinct statutory roles. There's a lot more to what happens, but I think it's just important to kind of outline the minimum requirements of a board. You go to the next slide. So there are 6 safeguarding principles which drive the safeguarding agenda, and the board is at a strategic level. So there are partnerships, the partners, all the agencies that are part are responsible for delivering safeguarding in their organisations. But this is where we come together as a strategic group of a range of partners, and the principles that drive that are those principles that drive the safeguarding agenda, which are about empowerment, about prevention, about proportionality, and particularly that agencies aren't going any further intervening in people's lives than are necessary within a safeguarding context. They're importantly about protection, and we come back to that key word partnership, and accountability. So they're the 6 principles that drive all of the safeguarding adults agenda in all of the organisations, both at an operational level in the communities, but also strategically where we're setting the framework for the work that's been undertaken. The next slide, please. So the Brighton and Hove Safeguarding Adults Board has a number of groups that underpin the work. So the board is a decision-making forum, and it's underpinned by these subgroups. So we have a leadership group, which is primarily focused around the partners who contribute to funding the board, and those key strategic partners, statutory partners, which is health, the ICB, particularly the police, and adult social care, which is part of the local authority. And other partners are invited to that leadership group if there are particular topics. But that group really drives some of the work down from the strategic plan. And underpinning that, we've got 4 subgroups. One is the Safeguarding Adults Review subgroup, which is chaired by Healthwatch colleagues, and I'm grateful to Healthwatch for chairing that group. The Quality Assurance subgroup, which is chaired by Adult Social Care, Homes and Adult Social Care. The Learning and Development group, which is chaired by NHS Sussex. And we have PASA, which is our subgroup of voluntary sector, which is chaired by a YMCA colleague. So you can see that the subgroups demonstrate the strength in that partnership. Let's go on to the next group. And I just omitted to kind of just highlight for you that we have the PAN, what's called the PAN Sussex Safeguarding Adults Policy and Procedures Group. And that is East Sussex, West Sussex and Brighton and Hove come together, and they work jointly to have the same procedures across the 3 local authorities, because the coterminous partners are the ICB currently and the police. And so that makes sense that particularly our partners aren't operating 3 different policies or practices. There's some synergy in how safeguarding is delivered through those organisations. All 3 local authorities have signed up to that so that the procedures are the same across the Sussex partnership, the Pan-Sussex partnership element. It's probably a prudent time to say that there's been quite a lot of discussion within the group from partners, particularly around the ICB and police, about combining the West and East Sussex with Brighton and Hove because of their diminishing personnel and because they feel that learning across the piece may be more beneficial. It's clear that each local authority area has to have their own Safeguarding Adults Board. And certainly I would say, and the local authorities are clear, that each local authority area is distinctly different, and certainly Brighton and Hove is distinctly different from East Sussex, which is the other area I chair. And therefore it would be not the best move for those local authorities at this point because of the differences around focus on the localisation of local issues which will come through. But one of the issues that we have worked with on the partnership, which partners have worked with, is around combining the Learning and Development group on a pan-Sussex basis as the Policy and Procedure group, purely on the basis that learning can be shared across all 3 local authority areas. And so part of the change that will be made is that there will be a pan-Sussex Learning and Development group, which has been supported across all partners, including the local authorities, because that does offer a good learning experience, and it also means that resources are allocated appropriately and everybody's learning. If there's an issue in Brighton and Hove around housing or homelessness, East Sussex and West Sussex benefit, and likewise. So I just think it's just important because that has been quite topical in the partnership discussions. And I think that the other bit that we're mindful of is the local government review, and that boundaries were likely to change, and therefore issues could be re-looked at. But it is clear that each local authority area has to produce their own annual report, and so the decision has been quite clear around the 3 local authorities as they have distinctly their own board. And I see nodding around the room because some partners here have been aware of that discussion, but I think it's important just to kind of give you a flavour of some of the discussions that take place at that strategic level. So the role of the Safeguarding Adults Board, and just to really just list out and just summarising really about assuring that local safeguarding arrangements are in place as defined by the legislation. It's about assuring itself that safeguarding practice is person-centred and outcome-focused. about that working collaboratively to prevent abuse and neglect where possible, because there is a role about what can be done around prevention. And whilst there is a focus of part of the board around learning from where things haven't worked out so well, it is about trying to, as I think we've already heard in the previous items, being there at the beginning and trying to prevent abuse and neglect where is possible. So ensuring that agencies and individuals give timely and proportionate responses when abuse has occurred, and assuring itself that safeguarding practice is continually improving and enhancing the quality of life for adults in its area. And so my role as a chair is to ensure that those partners are challenging themselves on their assuring me as the chair that those issues are being addressed as part of the ongoing work. And so I offer that kind of challenge at times, that assurance that people assure, and obviously part of the role is around sometimes offering advice and guidance around that and enabling discussions to take place openly and transparently. So we move to the next slide, which is about safeguarding adults' views, and I did refer to that at the beginning of the presentation. So Section 44, which is of the Care Act, mandates safeguarding adult boards to conduct reviews where an adult with care and support needs has died or experienced serious abuse and neglect, where organisations did not work well together to mitigate that abuse and harm. And it's where safeguarding practice can be approved by identifying what is happening, what's helping, what was hindering that safeguarding work in order to tackle barriers to good practice and prevent and protect people from further abuse and harm. And safeguarding adult views need to be good quality and need to be able to share, to maximise the value of their learning. And that's been some of the benefits of looking at a Pan-Sussex learning subgroup, because then that learning can be shared across that whole Pan-Sussex area, so they can learn from us and we can learn from them. It is important to say that the key to the legislation is around learning. It's not an investigation, it's not about blame, it is about looking in a neutral, transparent way with those involved why partners didn't work together effectively. That's the key to the Safeguarding Adults Review, so that practice can change. In line with many local authorities, there have been an increasing number of referrals around safeguarding adults reviews, but we have had 2 produced, which are on the website this year. There was Frank, Paul and William, which was a thematic review because the issues were very similar. Well, we thought the partners thought issues were similar at the outset. There were some similarities, but there were also differences. And sometimes if you see something that's thematic, it's helpful to bring it together, to look at it in that way. And we had Sar Henry. These are pseudonyms. Obviously, families are involved in these reviews where they wish to be, and so we generally consult families about whether they want to use their own name or a pseudonym name. So these are pseudonym names that have been used, but we are required to publish those on the website. So the Safeguarding Adults Reviews are on the website if members want to have a look at any time those that have taken place. Yes, sorry, I was just checking that. So just to kind of identify what our strategic priorities are, you can see we've outlined the strategic priorities are accountability, leadership, performance quality, communication and engagement with communities, inclusion and workforce fit for the future, and informed voice of the person. And this year I suggested it may be helpful to have a focus on asking questions. What are the answers to the questions? How do we know we are learning? And how does transitional safeguarding support people? And we've already heard today again transitional safeguarding being discussed in other topics. So it is topical throughout the themes, which is also good because you can see the thread of the theme being picked up. And how do we deliver prevention in safeguarding? And it is probably also just important that one of the things that I've been striving for since I became chair is to obtain feedback from people who are involved in safeguarding. That's a hugely challenging task because safeguarding isn't a voluntary process. It is usually where people are at high risk, they're most vulnerable, they don't necessarily want intervention from partners, and so it is a very vulnerable time of their life. But we have started a project in looking at, with Health Watch, talking to people, because actually if you don't know what people say, you don't know what the experience has been. So that work is in the early stages, but in the report you will see we've got threads of getting feedback from staff and other people and partners as part of the theme to bring the report alive rather than it being just a document that's sterile. I like to see things that follow through that. So just to kind of just draw us to a close before questions, the key activities during 2025 and 26 are listed in that we've done some self-assessment and peer challenge as a board. Self-neglect policies and procedures have been reviewed. This PAN Sussex Policy and Procedures Group I've talked about with you. There's been an audit on homelessness because rough sleeping has become part of the scrutiny around adult safeguarding in the last couple of years. We've got a local data dashboard, a sort of temperature check of where our data is to help us with our kind of checking where safeguarding is. I've talked about the reviews. We've got a multi-agency risk management framework, which again is about partners working together. And we had a very successful transitional safeguarding conference with the Children's Partnership in February, which was really well attended and had some really eminent speakers. And I've already discussed the lived experience work with Health Watch. So next year, just to kind of flag with you the areas for consideration, is you'll notice in the report that there is an increase in year on year of safeguarding activity. The business unit has suffered from reduced resources within the business unit in the last year, and that has meant that some work hasn't always been delivered because it's not possible for one person to do the work of 3 people. So there has been a focus on the statutory nature of the responsibilities. And one of the other facts is we haven't got any formal agreement for a funding structure from statutory partners for the future. Safeguarding boards traditionally have been funded through local authorities, primarily with other partners contributing. There's no set formula around how that should happen, and certainly that's something we need to stabilise in the future, is the partnership, because it is all partners need to be contributing, particularly statutory partners, to that funding. And that partners reduce resources in terms of funding and personnel. It is the partnership's budget, so the partnership needs to manage within its funding, and it needs to work within that funding formula or be agreeing how that's contributed on a year-on-year basis. We're obviously kind of considering the impacts of local government review because there may be changes ahead, and the new National Safeguarding Board may bring with it changes that Baroness Casey is looking for. We don't know what those will be, but certainly there will be more oversight of safeguarding boards in the future. I shall hold it there and hand it over to you, Chair.
Amazing. Thank you so much, Shona. Does anyone have any comments or questions for Shona? No? Go ahead. I'm sorry, Shona, you have to release the microphone, so I was going to...
Thank you, and thank you, Chair, and thank you, Shona, for going through the report. I'm Deb Austin, Director of Children's Services at Brighton and Hove City Council. I just wanted to pick up on the funding issue that you raised. As one of the designated safeguarding partners for the Brighton and Hove Safeguarding Children's Partnership, I'm aware how important it is to have secure funding arrangements in place. And I suppose it was a question, and I suppose a bit of a comment really from me, whether or not there was any drive for a pan-Sussex approach to funding arrangements for Safeguarding Adults Board. I think it's great that you're the independent chair of the East Sussex Safeguarding Adults Board, so you're in a really good position around that. And with that, perhaps some opportunities for some joint work on a pan-Sussex footprint. My experience from a children's perspective has been that colleagues from the NHS and from Sussex Police really welcome any kind of pan-Sussex approach, given that that tends to be their footprint. And I'm just wondering if that could be a way in to kind of get a bit of an MOU or a service level agreement in around funding.
Yes, please, Shannon.
Yeah, thanks, Deb. It's a really difficult one because we've had the discussion about a pan-Sussex approach to funding. The thing is, I think that there'd need to be agreement because the three boards have to still provide the same services from a board perspective, and the issue has been around what that is, because it has been very ad hoc in the past. So it's been a bit of, well, we need a bit more this year because we've had more Safeguarding Adults reviews, or we want to do a project. And so it's been a bit on that basis. And that's been one of, I mean, I've been trying since I came to try and get a stable memorandum of understanding, even if it's just inflationary uplifts, because salaries uplift annually. But we've kind of loosely agreed some of that, but everybody says, well, we can't commit to that because of that change. And it hasn't really progressed on that pan-Sussex basis. The pan-Sussex discussion has been about putting the boards together because that will create more efficiencies. And what we know is if you want a localised resource and local responses, and I think particularly for Brighton and Hove, because of the city status and because of the generation of people that come to the city and how the city is, the issues that are addressed in Brighton and Hove are quite unique. I don't know about West Sussex, but I can talk about East Sussex, are quite distinctly different. And so that debate has been more of the conversation about how you put it together and about the local authorities being really clear about not. So the discussion about money's been discussed, but we haven't progressed. But any advice from children would be helpful.
Yeah, go ahead, yeah.
Yeah, if I can just come back on that, I'm just looking at the report. The major contributor is the City Council, so I think there's probably a role there for the DAS in terms of flexing his muscles a little bit, in terms of the conversations with the other partners around that. I recognise the Children's Safeguarding Partnership is on a statutory footing, so there's a really clear expectation around that. But I think keeping adults safe is as important, because oftentimes it's young adults that we're talking about. Thank you, Chair.
Thank you, Deb. Steve wanted to ask a question or make a comment.
Thank you, Chair. Probably more of some comments and questions, but thank you, Shona. Thank you, Guy, for your work around the annual report as ever. I've got a few comments, I think, probably around increasing demand. I think we really recognise across adult services this year that demand around services generally, including safeguarding, has increased quite significantly, and we're now back at sort of pre-COVID levels in terms of demand for services. And I think in terms of how we respond to that, I think your comments, Deb, around sort of pan-Sussex work, we are undertaking some work at pan-Sussex with Sussex Police around demand management effectively, and around the numbers of referrals that the police send into adult social care departments that aren't necessarily related to safeguarding concerns, and thinking about how we manage that. And I think the police are really on board in terms of those pan-Sussex issues, despite the differences between the three places. I think in terms of the money, you're right, the local authority pay much more than the lion's share of our contribution towards the SAP budget. But I think this pan-Sussex work might be a bit of a way in to be a bit more equal about how those funding arrangements are reached. Because if you look at the level of demand across the three SABs, proportionate to our size, they are quite different. And the demand coming into Brighton and Hove as a city, particularly around our working age adults, is significantly different to our East and West Sussex colleagues. So I think there is an opportunity there which we can pick up Guy and we can pick up in the next board. So thank you.
Amazing, thank you, Steve. Can I ask you a quick question? Oh, sorry, go ahead, Tom. And then Alan.
Thank you, Chair. Tom Lambert, I'm one of the two voluntary sector reps here this evening. My day job is with the Carer Centre. I just wanted to place on record that it was through the commitment and the networking skills of the Health Watch rep that you mentioned that we were invited to be a part of the passive voluntary sector subcommittee. So I guess I use that as a very small example as an invitation for you to speak a bit about the impact of Health Watch in terms of their contribution and what effect we might feel in the next year or so if the proposed abolition of Health Watch proceeds.
Thanks for the question, and certainly I think I raised it. This was raised last year, and I think I said that I was very concerned last year when I heard about the decision about Health Watch, because certainly I think I said last year Health Watch are very engaged in the board from a number of aspects, particularly chairing the Safeguarding Adults Review. And I think it's a huge loss, and also it's about hearing people's voices, and if we don't hear the voices of people, then how can we improve our role? Because in the little bit of work that we've done already, everybody thinks they're doing okay, and some of the feedback already, just the very early stages, is, well, actually, yes, some of it's okay, but some of it, this is what we're hearing, and actually, we can be blind if we're not hearing the voices of people. So we're seeing already in the first few little bits of work that have started this year, because it'll be realised more next year, the benefits that independent voice has in talking to people. So by Health Watch going and talking to people in the community about their experiences, they're getting really rich feedback, and that would be lost. And you raise the voluntary sector, and the board manager will know that the PASA group was not attached to the board. It was distant from the board, and I've made it a subgroup of the board, because that voice is so important of the voluntary sector being at the table as an equal partner in the board, and we're trying to work hard to enhance that group even more, because the voluntary sector's voice gets lost if we don't have it at the table, because the voluntary sector, as you know, see people every day of the week, quite often 2 or 3 times a week, and the richness of the information you bring about people's needs can't be lost, particularly in safeguarding. The first person might be yourselves that pick it up. So, yes, I can say I'm fully supportive. Yes, very concerned that Health Watch abolition has been put on the table, and how that's going to be affecting us on the board, particularly around our subgroups, but also for people in the community and hearing people's voices.
Thank you, Tom. Thank you, Shona. Alan, you wanted to comment?
Thank you, Shona. Thank you, Tom, for those comments. I won't dwell on that. I think the other aspect of it is it's not just hearing the user voice, it's the independence that an organisation can bring, and bring that scrutiny, external challenge that will be lost as well. So we continue to fight the battle. I want to put on record my thanks to Shona and Guy for their superb leadership of the SAB. I think over the last couple of years it's really developed into a very strong group of partners. The partners are fully committed, and it's actually a pleasure to be part of that group. They're really passionate about trying to improve safeguarding for the whole city. I want to put thanks also on record to Bridget Day for chairing the SAR. She's a volunteer, and she does it with such compassion and dedication. I'm really pleased that the user voice is part of the strategy for the next 3 years. I would say that, obviously, but it's critical that we hear from people who actually go through safeguarding practices what their experiences are. And it's interesting that the 3 themes coming through already are people feeling that agencies aren't working together as well as they could, that almost when the safeguarding comes to an end, it's a cut-off point and people are just left. And interestingly, the third one is people have no idea what safeguarding is. So when they're told they're subject to a safeguarding concern, they don't understand it. And I think this feeds into the resource, possibly, sort of discussion. A lot of safeguarding sort of alerts put forward to the council, the majority of them aren't actually a safeguarding concern, but that still involves a lot of work for the council to actually go through those. So I sort of my challenge to all partners here all across the city is how can we make safeguarding easy to understand, so that we talk about safeguarding being everyone's business, but if that's the case, everyone needs to understand it, and that people don't, even professionals don't understand it. So I think what I would like to see is commitment from us to work together to make it easier for people to understand what is safeguarding, so that the true cases are funneled through to the council, so that they get seen and dealt with much more quickly, and the people who aren't a safeguarding sort of threshold get the support they need, which isn't safeguarding. So that's my sort of challenge to partners. Thank you.
Thank you, Alan. And if I could just add to what Alan's saying, it's kind of related to it. You mentioned that you'll be leaning on the voice of lived experience in your work going forward, and kind of related to what Alan is saying. Will you be talking to people who have attempted to make a safeguarding referral, but it hasn't actually been one, in order to find out what category mistakes they're making, and that can be used to simplify or improve the communication about safeguarding?
So actually, the work is being undertaken and being commissioned through Health Watch. And yes to all the answers of that. The purpose is, I kind of feel really passionate about people having a voice at our table. I talked earlier about acronyms. It's just something I kind of think, let's talk in language we all understand. And I think that Alan's early work is showing, his team's early work is showing exactly what needs to be done, and it will drive forward the safeguarding agenda. We need more publicity out there. We need the messages to be simple. We need information to be clear when people are a result of safeguarding. What does that mean? What's going to happen to me? What's going to happen afterwards? Where can I go? We need to simplify it. So we're hearing already work that's going to drive the board for the future in terms of improving people's understanding and ability to prevent abuse and also protect them from abuse.
Amazing. Thank you, Shania, and thank you for your presentation. With everyone's permission, I'm going to move on to the next item, but not before I ask the board, do they agree to note this report? Thank you. Noted. Thank you again, Shania. Okay. So that now brings us on to item 8 on the agenda, which is integrated community team. Oh, sorry. Item 10 on the agenda. Sorry, you confused me by putting numbers in the wrong order. Employability and health. And Chaz Walker and Lisa Mitchell, the BHCC Skills and Partnership Manager, will now present this. Thank you, Chaz, and thank you, Lisa. Sorry.
Yeah, hi everybody, I'm Chaz Walker, I'm the Programme Director for the City's Health and Care Partnership, and I thought I'll just quickly introduce the item, the reasons for bringing it to the board, and then hand over to my colleague Lisa, who will go through the sort of details. So most of you have been involved in our sort of recent board development sessions that we've been holding over the last 6 months, and within those board development sessions we identified the unique opportunity health and wellbeing boards have to influence and work from the perspective of the wider determinants of health. So, especially as a local authority committee, being able to work across a number of local authority functions and bring that work together within a partnership. So, we thought it'd be helpful to bring to the board some of the sort of detail behind sort of our employment work locally. So, as employment is a significant factor as a determinant of good health. So, so in the covering report, we provided some data on both employment and some of the linkage to health, and particularly the correlation between sort of deprivation, high levels of unemployment, and then the linkage to health, and particularly health inequalities, which we know is something this board really wants to focus on and tackle. So really pleased that colleague Lisa, who's works on the council around our work around employment is going to provide an update on some of the work we're doing across Sussex, some of the work we're doing locally, and then particularly some of the national programmes that are kind of about to get underway around a particular focus on health and employment. So I'll share my screen, please.
Thank you,
and, bring up.
So I've just got the light shining right in my eye. See if we can go to the next screen. Thank you. Thank you. Oh, I do apologise. That's quite small.
I'll do it as a.
Thank you, that's better. Still relatively small, but I won't cover every point. So, hello everybody, my name's Lisa Mitchell and I'm Skills and Partnership Manager at Brighton Hove City Council, as Chaz said. I thought it would be very helpful to start off with a bit of the context around the national policy drivers, which is set in the context for the work that we're undertaking at the moment. I will pick a few things out, as I say, so that we're not going through everything. But I think that the key thing that's going to be happening this year is that through the Strategic Authority, we'll be creating local growth plans. As part of that, there will be a strategic skills plan, which will set out what the priorities are for Brighton and Hove and Sussex. And obviously, skills supports employment. So that's very relevant to this area of work. Nationally also there is an Employment Rights Act which is improving the quality and security of work, and I'll be going into a little bit more detail about the Get Britain Working Plan, which the government has introduced to support people to reduce economic inactivity and support people into employment, and that translates locally to the Get Sussex Working Plan. There's quite a significant piece of research done by called the Mayfield Review, and that's looking at the role that employers take, how important they are in retaining people in employment. And they've actually signed up at least 200 employers to be vanguards, to have a real focus on how they can support people to retain work. And as I talk about Work Well, a new programme that's coming on board, you'll see the relevance of that, because part of that is retaining people into work. But also we are employers around the table here, so it's helpful to be aware of the important role that employers have in supporting people to retain work as well. The NHS plan, Chaz has mentioned around the focus on population health, and restructured integrated care boards that actually are going to have direct funding now to support programmes like Work Well, which we'll be implementing locally. There's also significant youth strategies around improving health and well-being of young people, which is aside from the employment, but is also really important in supporting people to move forward to employment. Thank you. So I guess why is this important? Well, we know that good work is really good for, important for good health, and we know that poor health is a major barrier to people finding work. People are falling sick earlier in their working lives, which obviously has a long-term impact on their own economic prosperity and that of the city. We have an increase in economically inactive residents across the city and across the country, and also persistent unemployment for young people. This is a big major issue of which we'll be talking a bit more about in a minute. Yeah, as I've mentioned, significant increase in mental health challenges for young people too. Thank you. So I guess what's available at the moment locally. So we have mental health and employment support. I put Mind there, also delivered through South Down. We have a Quell online platform which people can access to support their mental health, and we're publicising that across the services and the people that we work with so that people can access online support that's free to them. There's the NHS app, and also social prescribing, which is really important, and we will be connecting more with social prescribing through Work Well. But at the moment, they don't social prescribe around supporting people into work. Hence the importance of the new programme that's coming on. In terms of employability support, we have IPS for drug and alcohol and severe mental health, which is delivered by South Down and CGL, and we're linking with those services.
We also have Connect to Work, which I'll talk about in a moment, and Work Well coming on board in November. Thank you. So I've mentioned the Get Britain Working Plan and then the Get Sussex Working Plan. These are the principles that underpin the strategy. So it's very much localised, focusing on your local area, in this aspect, Pan Sussex. It's a review of the system, so we're going to be working in a systems way which is different to how we've worked before. And it's going to be evidence-based, so we deliver the services that we know that people need, and we will have the evidence to back that up. It's very much support-focused, a move away from compliance. So the DWP services at the moment are very much focused around compliance. There is a review of how the DWP operates, and they will be converting into a employment and national career service. So that moves away from compliance to around more holistic support, and much more around collaboration. So how we work as anchor institutions and core institutions to support the aim and implement the strategy. Thank you. So the Get Sussex Working Plan, which is the document that's informing the work that we do, and which was signed off by the DWP last year, and also through the local governments within each of the local authorities. It was developed across Pan Sussex. We did consultation here in Brighton, and later on there is a link to the documents and also the consultation, so you can see what the feedback we had that informed the development of the plan. We've had the plan, I've mentioned the endorsement. So going forward, the plan will transfer to the strategic authority and will also inform the strategic skills plan. But at the moment, we're continuing to work across Pan Sussex around shared priorities, but also localised priorities as well, where they exist. There is actually a lot of synergy across each of the areas. So what we have is the core challenge remains the same, but there is nuance around certain areas. For example, transport in East and West Sussex, where there's more rural communities. But overall, we do share many of the same challenges and opportunities. Thank you. So the vision for the plan is set out there, and I just want to draw your attention to the fact that it supports about addressing inequalities and around integrated support across employment and health. So those are the key words that are framing the Get Sussex Working Plan, and important for you to be aware of that. Thank you. So you'll see them when the slides are shared. I think they've been shared in advance. But these are the challenges that we are addressing. And I will just pick out a couple of there that are particularly relevant. So barriers for young people, unequal economic activity across Sussex, fragmented support services, lower skills and qualifications. So, you'll be familiar with many of those things already. Next slide, please. But also opportunities. So being able to grow a diverse economy, the benefit that we bring together as anchor institutions to work collaboratively to address some of these challenges as well. So all opportunities that we want to harness through the implementation plan. Next slide, please. Thank you. So the plan sets out 6 ambitions, and again I'll draw your attention to number 4, which is to respond to diverse place-based needs to increase economic activity, health and well-being outcomes. So the plan has priority groups and the ambitions, and I think on the next slide there we have the priority groups. Yes. So young people, residents age over 50, disabled and neurodiverse individuals, global majority communities, parents and unpaid carers, adult with low-level skills and low income, and then economically inactive. And then there is their link to the stakeholder report. So these priority groups are framing the activity that we undertake across Sussex and in Brighton and Hove. Thank you. So the employability programmes that are funded at the moment through the Department for Work and Pensions are Connect to Work, which was launched last year, Connect to Work supports people who have longer-term health challenges or barriers where they need quite significant support. The support can be up to 12 months, and the pathway they will follow will depend on the challenges that they present with, whether they have a learning disability, where they may need a supported employment approach, which is supporting job carving and much more bespoke support that individual might need to get into employment. It also supports people that are in work to stop them from dropping out of employment. So, as I say, that programme can be accessed for up to 12 months, but it's very much work focused from quite an early stage. And Workwell, which is coming on board in November, is supporting people with lower level health needs. Again, they may be in employment, but they may be signed off with a medical certificate, and they will be referred to a health and work coach to support them to have a plan of action which will help them either return to work or address some of the barriers so that they're better prepared for employment in the future. Thank you. So the Pan Sussex implementation plans, the Get Sussex working plan is a 10-year plan, but it has shorter and longer term ambitions. Many of the things we're working on already around partnerships, and there may not be any funding that is required. Other programmes like Connect to Work and Workwell, they're very reliant on DWP funding. And there are other areas that we've identified where we really cannot move them forward without additional funding coming forward. So we're actually in the process of developing a paper to give to the Strategic Authority to identify where some of those gaps are, so that when there is funding down the line that they are kind of well aware of what they are and what we need to be focusing on in the future. So I'll pause there. I appreciate that I have whizzed through that quite quickly. There is a lot of information, but happy to take any questions or to respond to any questions by email or separate approach if that would be more helpful.
Thank you, Lisa. Does anyone have any questions or comments for Lisa? Go ahead, Tanya.
Thank you, Lisa, and really great piece of work in terms of the presentation as well. And obviously, I think from an ICB point of view, we've been part of the Workwell journey and certainly piloted in the city, in the East Brighton area. So my question is, with the data being very clear that areas of greatest deprivation are some of the outliers, do we have a sense for the November rollout of the new Workwell programme of what those areas are? And in the city particularly, is there areas being focused on that you could share now or maybe after? Thank you.
Thank you. Yeah, so Workwell has to be a universal offer, so we're not able to turn anybody away who isn't eligible to receive support. But what we are looking to do is when the health and work coaches come on board is to align them with the ICT geography so they can start to build relationships with primary care networks and really within those communities. So I guess we're going to have about 5 work coaches, so I think that we will assign the resource to where the greatest need is, and we know where the greatest need is, east and west. So that's where we'll be focusing support, but it is a universal offer, so anybody who is eligible can apply. But we want to make sure that it reaches the people that really need it as well. So there'll be some quite targeted marketing as well.
I think part of the discussion's been, we've had, because Lisa, you attended some of our integrated community leadership groups, and I think there's real opportunity for those groups to bring value, add value to, so you have that funded piece, but actually, I think what we saw when we worked in the East was how important it is to support primary care. Often they're the sort of gateway to around sort of sick notes. So, and actually we know how much pressure GPs work under. So if we're able to work with GPs so they've got a range of resources, understand how they can sort of refer people on, so they're not just doing sick notes, but they're also providing some level of input into how, so we think there's real opportunities with the integrated community teams to actually work and add value to the Workwell programme as it's being sort of commissioned sort of nationally.
Yeah, definitely, thank you. And the DWP are actually piloting some different approaches in parts of England. So in some areas, they're looking at fit note reform at an earlier stage. So, for example, in one of the pilots, they're not referring people to GPs at all, and in others, they're going to GPs and then directing people out. there is actually a real interest by GPs from the ICT meetings that I've been to who really want to do more and recognise that people, probably could do with more support than they're actually getting. So I think that we're really well placed to respond to that appetite, working with the ICT colleagues. And we'll be doing a piece of work before the launch to start putting those foundational pathways in place.
Amazing. Tanya, did you want to follow up? And then I'll come to Steve.
Yes, just a slight follow-up, and I should have said I'm Tanya Brown-Griffith from the ICB, but because I've been on the board so long, I forgot to introduce myself to those who don't know me.
Sorry, Tanya, that's my fault. I didn't get people to introduce themselves.
It is my last board, so please excuse me on that. But Lisa, I suppose I was thinking, as commissioners, we do commission some social prescribing additionality. So how can we work together to ensure that we're utilising all the resource and not just dependent on those few people that are going to be part of WorkWell? It's just a suggestion for taking this outside. Thank you.
Thank you, Tanya.
I have had early conversations with the social prescribing contact and the PCNs as well. So that will be part of the preliminary work we do to create those pathways, absolutely, key part of that. Thank you.
Thank you, Tanya. Was it specifically related to this point, Nikki? Okay, I'll let Steve go, then I'll call you.
Thank you, Chair. Thanks, Lisa. It's a great presentation, really, really good work. And I wondered if, do we have a sense of how the sort of strategic authority might help lever in resources? Because I guess one of the key elements of the Sussex and Brighton Strategic Authority is about having a prosperity plan and looking at kind of economic growth and levering in resources. And I guess one of the key things for our city is that it's a really expensive place to live, and lots of employees in the city can't afford to pay a lot of money. So I suppose there's something about, do we have a sense of the things that we're wanting from the strategic authority, or is it still too kind of early days?
I mean, from my point of view, the Strategic Authority have recently employed an interim skills lead. So the conversations that we're having with them at the moment are to create the strategic skills plan that we need to have a first draft of by September, creating the priorities paper around some of the gaps. But they do absolutely recognise that the employment aspect is really important to inform the prosperity strategy. So I guess it's still very early days for the Strategic Authority, but we are having those conversations. There was a sprint a couple of weeks ago around, the thinking and how we worked collaboratively to achieve that. So I think that we've got strong foundations and we're going to work with them. They're very keen and open. In fact, the Skills League visited us last week.
Thanks, Steve. Thanks, Lisa. I'll go to Nikki and then you, Jessica.
I'm Nikki Lang, Director of Public Health. Nice to see you, Lisa. We're very interested in this, and I think, as Tanya said, thinking about social prescribing, but also Recovery College on the mental health side, and then obviously we contribute to individual placement support. I mean, is it your feeling that for our vulnerable clients, they need more readiness and time to sort of get work ready and have volunteering, or is it a bit what Steve said about employers being ready and then being able to then provide support? Just because we do have so many people in the city who have, I wouldn't say low-level health issues, but it's a more sort of global issue, but they would really benefit from being in work. So is there anything that we can do to help?
I think we need to look at both perspectives. We need to look at what we can do to support employers. And actually, this is one of the things that we've identified through the Get Sussex Working Plan. Employers need support, particularly in Brighton and Hove and across Sussex. We've got a lot of small employers. It can be quite difficult to navigate. We know that people need support. That's where community-based interventions are so important. And community-based funding around employability is lacking, and that's one of the gaps that we've identified for the Strategic Authority, because previously we have had shared prosperity funding, we've had EU funding, which has funded place-based local interventions. Now, the schemes Connect to Work and Work Well are brilliant, but they are quite big schemes, and if you're not quite ready for that, there's not a place for you. So that is a gap. So I guess in terms of what you can do to support, I think we need to be making sure that we're talking about what those gaps are and how we can accelerate funding. And again, this is Pound Sussex. So, we've very clearly identified community funding as a gap.
Thanks. Thanks, Nikki. Thanks, Lisa. Jess.
Thank you. And it sort of links both Nikki and my question links both to Nikki and Steve's points actually. And it's sort of two things. One is, have you got any advice to us as a board about what further devolved powers or devolved funding could come to government, both to the strategic authority, but even also to local authorities, and what we should be lobbying for in this space? And is that, part of what DWP do? What would you recommend? And then the other piece for me is around the recent Milburn NEETs report, and what's the learning from that you're taking on board into this, or that we should be taking on board, in your view?
Sorry, thank you. So in terms of the strategic authority and the lobbying, the paper that we've written is very clearly articulating what we think that those gaps are. And they are around provision for young people. Lots of young people, they go into college and then they fall out of college and then there isn't an offer for them. So then they become unemployed. I've mentioned the community-based provisions, support for employers. So very happy to share that paper with you, Jess, we're still in the process of finalising it, but I think that would be very helpful if you could champion that for us. And the other aspect about the Milburn review, the government has already announced the youth guarantee, so we know that there are grants available for employers. They can apply for a grant up to £3,000 if they take a young person on. So we've been started to publicise that in the city. It was only launched a couple of weeks ago, so that's something that we can do. We have our youth employment hub in Kemp Town. We're just about to put in our bid in for Year 6 funding. And that's a place for vulnerable young people to come in a nice space rather than go to the job centre. And we know that a high percentage of young people that come do have a vulnerability or a disability, and they need that extra support. So I think that we are very much aware of what we need to deliver for young people, because we know that there's been a significant increase in unemployment only in the last year, and also around our NEETs, sadly, as well. So young people 16 or 17, that's significantly increased as well. And I guess we need the resource to support those young people, but we also need the opportunities. And I guess the council as an employer and other large employers around can also support by looking at their own HR practices and what they can do to unblock opportunities for young people, so that we're actually, role modelling what we want other people to do. And I guess sign up as one of those vanguard employers as well that I've mentioned earlier as a result of the previous review, to demonstrate our commitment. So very much we are doing what we can to support young people.
Thank you,
and
Lisa.
Connect to Work as well is an offer for young people as well.
Thank you, Lisa. Thanks, Jess. Lucy.
Thanks, Chair. Keeping with the sort of the young people thing, thinking about transition, and actually sort of by the time people become NEETs, there's sometimes there's already a sort of a mindset. I'm just wondering if there's any way to sort of do some work in schools when children are younger, more receptive, sort of saying that these things are out there to support you. Sort of schools could pinpoint people who maybe have some disabilities or in danger of becoming NEETs, and to actually sort of get in there and work with them before they left school. So actually they look at employability as a really positive thing that they can get into, rather than coming out of school with a more of a negative mindset for work.
I think the important thing to note is that the responsibility for careers and careers advice and career pathways sits within the education system. So the statutory responsibility to the council when that young person has left secondary school. So we do have networks of the secondary heads and post-16 providers where we do talk about some of the challenges, but that responsibility ultimately sits with them. What we do is we have an early referral form into our DEEP team. So if that school knows that the young person does not have a place and is very likely to become needs if there's not an intervention, we will work with those young people first. And the referrals we had this year exceeded what we'd had previously. And then we're also working quite closely with our sixth form colleges and sixth form and FE, sorry, the word escaped me, around the vulnerability index. So what they can do to identify young people more quickly as they enter so that they can put the support in place. Because often there can be a gap of information going into those establishments, particularly maybe if a young person hasn't got the grades and then has had to move into a different offer than they're expecting. So, you know, those colleges need to be prepared to support people quite quickly, because if that support's there, then they're more likely to stay in. But where somebody does fall out of education, the college will do what they can to retain them. They will signpost them to us. They give us lists of young people that have left, and we follow that up immediately. I went into Brunswick a couple of weeks ago and I gave a talk to their team, again to try and increase awareness of our youth employment hub and what the offer is around. So we've got skills boot camps, which is another offer that people can access to support their training and development as well. So, you know, we are doing what we can, but we are a relatively small resource within the local authority, but we do have good networks.
Thank you, Lucy. Thank you, Lisa. Do you want to release the microphone, Lisa? Thank you.
I was just going to say, for a small group, that sounds like you are doing a lot. So thank you very much.
Caroline, go ahead.
Yeah, hi, thank you. And yeah, always good news that there's funding coming and work being done on getting people into employment. It was more an offer of help, really, because I think I've been around quite a long time now, so a few others, and we've gone through quite a lot of employment schemes that have been really successful but have been time-limited funding. But I've got all manner of reports that may well be useful for funding applications, and that's from like health coaching services for people with long-term health conditions, all the 6 groups that you mentioned on there: autistic people, carers, young people, the whole list. So I don't know if we can maybe have a separate call and share that information with you, and I can, you know, put it out around the sector.
Thank you very much, that's very helpful.
Yes. Thank you, Caroline.
Just say one more thing, that I think one of the things that we've always found is really, really important is getting people into work that they want to do and is realistic for them to do, and so they stay in it, because I think there's been quite a lot of employment schemes over the years where people get into a job and then 6 weeks later it's not manageable and they're back to square one, and that's just so demotivating for everybody, I think, for employers and for the person.
And that is what we do through Connect to Work. We identify really where the person's skills are set is. We do a vocational profile, so we understand what the skills are, what they want to do, for exactly that reason, because they're more likely then to stay. And we also look at carved roles as well, so they may be able to do one element of a role, and we talk to that employer to see if that can be achieved. So, and again, people are more likely to stay.
Thank you, Caroline. Thank you, Lisa. Tom, go ahead.
Thank you, Chair. Just quickly to point out the importance in terms of staff retention regarding supporting unpaid carers. Basically, I think there's 600 carers every day in the UK who are resigning their jobs because they can't manage the employment alongside the caring role that they have at home. And that statistic would translate to 2 or 3 people today handing in their notice in Brighton and Hove for that reason. And with actually relatively low levels of support, we can help carers to stay in work. Things like peer support schemes within companies, and making sure that our staff are aware of carers leave, which is now available to them. There are some small steps that we can take to support employers to retain their staff, and therefore reduce the cost and the training expense and time that they have to put into the recruitment of new staff as well. So just another point.
Amazing, thanks, Tom.
I was just going to say, maybe that's something we could pick up as an action from this, because obviously as a board, we have a carers is one of the areas where you have a focus on sort of thing. So I can probably make the link just to further a conversation around how we do action that and how, as we can better support potentially better support carers around their employment. So I'm happy to.
Thank you, Chas. With your permission, I'm going to move on from this item because I'm conscious we've got quite a lot to get through and we're running out of time. So before I do that, I'll just ask the board if they agree to note this report. Thank you. So that brings us on to item 8 on the agenda, the Integrated Community Teams Neighbourhood Plan and Governance Structure. So I'd like to invite Chas Walker, Jo Martindale, Chair of the West ITC Leadership Group, and Kay Duadoff, Chair of the East and West Central ITC's Leadership Groups to present. And also joining us will be Jo Walker of the East and Central Primary Care Network. That's a lot of directions. Thank you, and I'm sorry for butchering whoever's done butchered.
Thanks, Chair. It might just be the three of us. We were hoping one of our colleagues, Jo Walker, would be able to join. Sure. He's trying to, juggle a number of responsibilities, so that's just why there's the three of us. But if he joins us in time, he'll join us. If not, we'll cover his part. So, yeah. So, a bit like done before, I'm just going to provide a little bit of context around the report that was with the papers, and then hand over to my colleagues, Jo and Kate. So, we've got a presentation to support, so I'll just bring that up.
Thank you, Chas.
So, in the report we provided with the agenda, we identified that the importance around neighbourhood health and the new national neighbourhood health framework, which clearly sets out expectations around health and wellbeing boards in terms of their role around local governance of neighbourhood health, and also the requirement of health and wellbeing boards over the next 12 months to be developing place-based governance neighbourhood health plans. So we thought this is a really good opportunity today to sort of bring to the board the work of our integrated community teams in the city, which are the actual practical vehicles that we're delivering neighbourhood health. So rather in the papers we actually appended all the 3 plans. Rather than maybe going through the plans line by line, we thought it might be more helpful for the board if we started to bring to life what neighbourhood health is actually looking like in the city. So there's so much talk around the sort of, the national reform and the left shifts, and so we thought, rather than just go for the plans, we'd actually provide some examples of how neighbourhood health is being delivered across the city, hence inviting my colleagues Jo and Kay to join and support the presentation. So firstly, just a quick reminder for those that aren't so familiar about how we're structuring our sort of neighbourhood health infrastructure in the city. So this has been in place over the last sort of couple of years, and we agreed as a health and care partnership around a footprint for neighbourhood health. And the footprint basically looked at 3 neighbourhoods in the city, so what we call the West, Central and North. They're slightly peculiar shapes in the way they but there's a reason for that, is that the health and care partners felt it was really important that the footprints for neighbourhood health aligned with our primary care footprints. That's the sort of database of our patients across the city is held by primary care. It's the first point of contact most people go in terms of their health. So when we design the footprint, it corresponds with primary care networks, 2 in each of our ICT footprints. And primary care networks are the sort of model in which individual GP practices come together as a grouping and it around a sort of locality. So we also spend a lot of time considering as a city, because we are a condensed urban authority area, there are some things it makes sense to do once as a city rather than before. Oh, great time, Jo. I just explained that we might be or might not be. So thank you for rushing over. So So sometimes as a city it makes sense to deliver neighbourhood health once rather than divide it 3 times, especially when we're starting to think about particular communities of identity where they might not necessarily reflect a particular neighbourhood in the city but be a sort of a citywide issue. And one of those we've discussed a lot in this board is a good example of that is when we talk about our homeless and multiple compound needs sort of group, where actually we work at a city level to provide a neighbourhood health approach to that group. So and just lastly, that roughly around 100,000 of each the population live in each of those areas of registered population. So there's a sort of split, and then when you start to work down into a PCN level, that's around 50,000 population, which starts to reflect the concept of neighbourhood. So I think Joe, you're going to talk to this bit.
Yeah, this is showing you that at ICTs there's an aspiration around prevention and one about addressing health inequality, but also about addressing our population with the highest needs. And so over the past year or so, integrated communities teams have been testing a new way of working. When I say a new way of working, anyone that understands what an MDT or a multidisciplinary team is knows that it's not that new. But what's different is the risk stratification tool. And for those of you, forgive me, I think it's helpful to kind of outline that tool is something that looks at a GP's list and then is able, by using the coding that is contained within the data, to produce a list of people that are most at risk within that list. And to date, we've been using a list called the John Hopkins tool that's very much focused on over 65s and frailty. And we're moving to a different tool to be even more sophisticated, which is precisely focused on the segments of that GP's list that is most likely to have the kind of complex needs that are going to cause problems over the next 12 months. So where we as a multidisciplinary team could intervene and make a difference for that person. So MDTs are held at the PCN level, the neighbourhood level, apart from in Central where they're held at the integrated communities team level. So in West we have 2 MDTs. Over in East there's also 2, but in the Central North Strip they've come together, and that reflects the fact that we have a huge university in one. And really, so when you're looking at your list, those students aren't coming up as your most complex people, people with higher needs. So this is the very important high-end work. Adult social care have been embedded from the start in that, as have the community and voluntary sector, particularly the social prescribing organisations. You've also got from SPFT, the SOAMs, the older adult mental health workers, you've got the physios, you've got the OTs. And they've been working through a variety of cases. To date, we've had 268 patients come through, and as we develop as a neighbourhood alliance, which is at a system level, there's going to be a core offer and this work will accelerate. So if we move to the next slide, I'm not going to say too much about this. Caldecott makes it hard to share the detail that makes these things more interesting. But I think it gives you a flavour and shows the kinds of results that can be achieved with collaborative relational working for real people, because sometimes in the boundaries between we won't take that referral, that doesn't quite meet our threshold, people don't get seen in their with the whole information. And that is what this work has been able to do. And as I said, this work will be accelerating and will become more proactive to really start making an impact, hopefully, on the outcomes for that very complex cohort.
Yeah, that's right. So thank you, Jo. I'm going to talk to you a bit about, if you think of it, the population triangle with the complex needs at the top and the wider population at the lower end of the triangle. Tell you a bit about the reach we've done in making contact with all those members of the community who have health inequalities and what we're doing to sort of hear their voice and in sort of connect that into all our integrated communities teamwork. So what we've done is we've created community-led health prevention projects to try and tackle the wider determinants of health. And that's been working with about 200 groups and organisations across the city. So this is being delivered by the Trust for Developing Communities where I work and the Hangleton and Knoll project. So we're the community development organisations in the city. So we're able to we've got connections with the communities, we're able to build on those. So this is what we've done since April 25 up to the end of June. So we've had almost 600 health events, reaching over 7,000 people engaged in those events. So it's an enormous number of people who have been touched individually about something to do with their health and health prevention. We've done an enormous number of sort of cascading of online information. If you look, that 337,000 is bigger than the population of the city. So this is views, this is not individuals, but there's a lot of information going out and being reached and being shared on. We've reached nearly 59,000 people with hard copy information, and we know that really matters to people, of having something written that they can see and they can take home and they can share, and it can be translated for people. And we co-produce that information with community members, so it really speaks to them. And then we've done more tailored invitations of targeted to sort of specific things to specific community members, over 18,000 people there. And then the bit that sort of is the outcome of all that hard work of sort of collecting the information and the voice and sharing offers with communities is that we've then signposted over 2,000 people into healthcare professionals, so clinical support, who wouldn't otherwise have got it, and over 6,500 people into community support. So we're definitely seeing it as a sort of holistic offer of community and clinical offers working together. So I'm going to hand over to Jo, who's going to tell us about an example of reach into a particular community of need.
Sure. So I'm going to talk to you about the Trans and Non-Binary and Intersex Community Health Hub, which has been about a year in the planning and has been running for about 4 months now. And the genesis for its establishment was really a kind of a combination of the health counts data, which obviously public health and the universities put together, and the kind of community feedback that Kay's talking about. Now, the trans and non-binary population, of which health counts estimate that makes up about 5% of the city, and the LGBT population, or other than straight, about 30%, experience some of the highest levels of health inequity in Brighton and Hove, on a par with those living in core 20 areas. And there are obviously, for national and local reasons, been a population that are quite institution averse at the moment, and there is a huge trust deficit that exists between the NHS and the community, and the problems with that are kind of manifest, which is that you end up with GP avoidance, problems get worse rather than better. You end up with people doing DIY hormones, which can lead to problems later down the line without monitoring. And so we kind of approach this project with real trepidation, actually, because it needs to be handled really sensitively. And I think it's a really good example of where ICT work comes into its own, because it was through speaking and relationship building with Switchboard and the Clare Project, two of the charities that represent the population that we're talking about, that we realised that any work that we could do or wanted to do had to be through and with them. You know, there was no going straight to the community. There was no imposing services or some kind of idea of what we felt that they would need onto this population. It was about working slowly, carefully and sensitively with the charities that support these people to produce something that would be wanted, that would be needed, would be sustainable, and would ultimately start to turn the tide on trans healthcare and hopefully reduce those population health inequalities. And so we went live with what we called the TMBI Health Hub about 4 or 5 months ago, and it started as a monthly drop-in, so much like the White Hawk Health Hub, which you may have heard about in previous sessions, I'm not sure, but I'll cover slightly later. This is a no appointment needed service and is set up within a trusted space. So we've gone into the Clare Project weekly drop-in to deliver this because they trust that when they go there, they're going to be safe, they're going to be heard, they're going to be respected. We have an advanced nurse practitioner, we have social prescribing, we have mental health. We started small and we want to build up. What we want to do, though, is make sure that anything we do put in that space is wanted and needed. So far, the response has been pretty much an astonishing thing, and for me personally and professionally, it's been one of the highlights of my career so far, because this has been, I can't tell you how challenging this piece of work is, to work with people that, you know, are really so very reluctant to engage with healthcare. But I think can serve as a model for other inclusion groups if we kind of agree that this is a model that's worth pursuing. And I think to kind of highlight it, I'll just share the case study, which is on the next slide. Thank you. And this is a person who was living in the north of the city and had been doing DIY hormones for transition for several years, and they'd never had a blood test, they'd never had their bloods reviewed. It's obviously quite unsafe for this to be happening, and they'd experienced discrimination. They'd been misgendered repeatedly at their previous GP practice. They weren't offered a bridging prescription because you know, some GPs don't feel confident, able to do that. And so we spoke to them. I assured them that Rachel, who is our prescriber, would, you know, treat them with the absolute most dignity that they could imagine. And Rachel managed to get them registered with her GP surgery so that their bloods were done immediately. They were monitored. A bridging prescription was issued, so they're actually getting safe prescribing. It means that they're getting what they need to do. They've had a TMBI health check, which is part of the LCS. And since then, they've had like just the most amazingly transformative experience of GP practice. You know, and I heard it again today. I've actually just come from the TMBI Hub. It's rather serendipitous today. And all of this stuff goes some way towards establishing trust with organisations that many people feel are just too detached from them. And it's only possible in partnership with other organisations, and particularly with the third sector.
Thank you. So you've heard a bit about the core offer to the people in highest need. You've heard a bit about the sort of wider health inequalities work we're doing, and we've rolled that all together into delivery plans for each ICT area. So this is the example of the Brighton East one, but there's one for each area of the city. Now, we're not going to go through these line by line, as Chaz says, because there's plenty of time to read those. But just to say, these cover the membership, our approach, the demographics and the need, and they've been produced collaboratively. So we've got primary care, local authority, NHS, voluntary sector, some parts where the university is prominent, they are involved as well, hospital, SPFT, SCFT. So they're real collaborative documents where we've come together to do that. And the idea is, we've then put on the last column, which you can just about see, is the delivery plan. So those are all, there's something like 12 things that each ICT group are going to want to do over the next year. And then there's an accompanying document with that in more detail. So we've got it set out what the ambition is, and that's been co-produced with community voice and with collaboration. So we'll keep keeping these alive, but just so you know, that's what those documents are. I'm going to pass back to Joe to do a quick overview of the East Brighton Health Hub.
Yeah. And I'll try to keep it concise. Chad did tell me 2 minutes a slide, and I've just ignored him, so sorry about that. Yeah, so the East Brighton Health Hub was set up 2 years ago. As I say, I'm not sure if it's been discussed in other sessions, but we wanted to go to a community experiencing high levels of social and economic deprivation, White Hawk, high level of multiple deprivation needs, some of the highest in the country in the north, and bring our healthcare into the community. Again, it runs as a no appointment needed drop-in service where visitors can receive wraparound support for their healthcare and wellbeing. That includes responsive clinical care, such as physiotherapy, occupational therapy, nursing, alongside things like social prescribing, money advice. We've had over 25 third sector organisations with us, and I mean I couldn't possibly begin to reel them off now. But really, this is a vehicle for bringing teams together and for giving people what they need to stay healthier for longer. So far, the stats are a little bit out of date. We run every Friday from 10 till 1, but we've seen about 1,600 people now. I'm not sure how many appointments off the top of my head. There is a strong evidence base growing that people would have gone to their GP had they not come to the health hub. And so what we're seeing as a byproduct of this multidisciplinary working and actually providing alternative access to healthcare is increasing capacity. I suppose one of my concerns is when we talk about ICTs, it's really important to talk about the highest and ongoing needs work and the risk stratification of the people to reduce hospital admissions. We can't forget about the fact that we're trying to save people's health 5 years, 10 years and 20 years down the line, because that's actually how we're going to build a sustainable health system. And I think models like this and the similar models that they have in the West are the way to do it. I really do. I think people enjoy the fact that it's a non-clinical environment. It's set up in a housing estate in Robert Lodge, and they can see, our clinical teams, they see adult social care, they see the housing team, they see all these amazing organisations that serve the people in the city under one roof. I just pray that we start to kind of keep it going and roll it out, scale it up elsewhere. I think it's really important.
Thank you. So we're now going to move on to Brighton Central. So there's the delivery plan, which I won't dwell on. I wanted to tell you a bit about the community support hub that we're doing in Central. So just to say, we've got different models. There's sort of a weekly offer in Brighton East. There's a fortnightly offer in Brighton Central, and Joe will tell us a bit more about the one in the West area, which is more of a themed, larger event. So there's different ways of doing it, but they're all co-located walk-in offers. And what we're doing in Central is we're theming them. So we asked the community what mattered to them, what were the themes they wanted. And they wanted themed days on cost of living, older people, diabetes and hypertension, men and women's health, eye, ear and oral services. So we've then put together monthly sessions themed around these. So we actually then are targeting people who can come to those. And we're piggybacking them on existing activities that the community are already running. So if we go on to the next slide, I've just got a couple of examples to share with you about, this is the one in Hollingdean. So we've got one in Hollingdean, the community centre there, one at Old Boat in Hollingbury. So let's do Councillor Fowler's story first. So this has been published, so it's in the public domain. She came to visit the community support hub to offer her support and to take some photos. But our community pharmacist got in there and said, "Should we take your blood pressure?" She went, "All right then." And it was found to be high. She had known a while ago, but had never done anything about it. And he said, "Oh, we need to do something on this." Got her a free 24-hour monitor, and then she's been on medication since then. So you can go in as one of us and just not know that you've got high blood pressure. It's a silent thing. And she said, "What an excellent service, from the initial check at the hub to the follow-up from the pharmacist. Everything was straightforward and well organised. The pharmacist even phoned me a few days later to see how I was getting on." And that is the lovely Brajesh from Brighton Central. So he's our pharmacist lead there. And then there is a video of Old Boat. If you want to look at it, you could click on that later. But then I also wanted to talk to you about Simon, who visited the Hollingdean Health Hub. So he's a community member. He volunteers at the Real Junk Food Cafe, and we're co-located with them. He has mild learning difficulties, so he found it really easy to access the hub. Again, community pharmacist found high blood pressure and said, "You need to go to the GP straight away." And he said, "Oh no, it's too complicated, I can't get to the GP." So then he was supported at the health hub to change his lifestyle. And through that, he started going to the gym and lost 19 kilograms of weight. And it's still coming off. So he talks about having more energy, he can move more, he puts the tables out every week for the sessions, and he just says he couldn't have done it without the hub. So I just think those two stories are just examples of just having the right service in the right place. People walk in, you don't know what's going to happen, there's a different story every week. So I'm going to stop there and hand back to Joe.
We would need the whole of the meeting to talk about all the different bits of the work. But I think that event or hub, or the concept of bringing health to people is extremely powerful. And actually, it's back to what Joe was talking about prevention and about the health inequalities that exist in our city, because there are so many people who don't want to use conventional health service or don't have the time. And you can pick up a high BP and you really do prevent some very serious things, strokes, etc. afterwards. And actually, if you marry that with the risk stratification tool and you target specific groups of people who maybe are known to have diabetes but don't receive their care processes, there is a way of perhaps helping people help themselves, which I think is really, really important to this new way of working, that empowerment, that giving people the tools that they need and responding where they're at, that's really important. As Kay said, there's very, very small writing on here that I can't read now, but know that it's based with community insight on community priorities and on population health data. And though that's the kind of the core of ICT working, really, we're at the beginning of trying to shift how health is delivered. And to that end, if I could have the next slide, it's been a real joy to be here and hear children and young people talked about within the Health and Wellbeing Board. So often, children and young people aren't included in the conversation. And we had some questions earlier about how do we change up the model for our children and young people? How do we create a model that is more accessible, more inclusive, can get in earlier, that is non-medical, and that can support children and young people over time, not just with a few sessions here or a few sessions there. And ICTs are a big part of the answer to that. So across the Sussex system of 15 ICTs, there are 3 ICTs that are front-running to look at how children and young people could be better served with a collaborative, local, integrated approach. And in Brighton and Hove, that's us in West. So we held the inaugural meeting of this. It's a whole different cast list from when you work with frailty and adults. You're completely different people, and people that aren't always as well networked between health and social care. So it was a very buzzing set of people. We had 2 head teachers of our local secondary schools. We had our local GP, Adam, actually attended for Brighton and Hove Fed. We had the Drug and Alcohol Service, public health colleagues who have done loads of fantastic data work since, our community trust, our foundation trust. Importantly, our specialist mental health and community mental health services, and the community and voluntary sector playing a really big role there also in delivering the community CAM service, and also with our SEND young people with Amaze. So the priorities for children and young people that were identified were mental health and neurodiversity, asthma and vaccinations. That's both the top community priority for West area is children and young people mental health, but our population health data also shows that Brighton and Hove as a whole does not do very well for self-harm, but that the emissions from the west of the city are in fact the highest. And what ICT working allows you to do is really drill down and understand the nuances of our different communities, and enables that local response, because being able to have the secondary school heads talking with it's a very rich conversation. So subsequent to that, we are supporting the Vaccination in Schools programme. That's with the vaccination work that's part of the wider vaccination work with public health. And we're doing some very clinical work on asthma because we don't have asthma as well controlled as it should be, and there are new medications, and there's a whole range of interventions we can work within. Family hubs have already done a lot on prevention and asthma packs. Let's take that into schools, let's take that into youth settings, but also at the clinical end, how we bring our specialists from the hospital out to do specialist surgeries within our GP clinics and get the right young people there who are struggling to manage their asthma. I would love us to have, I'm like you, Joe, I'm struggling with my 2-minute brief, but I would love to come back and do more around the mental health pathway. In October, we're having the clinical psychologist from CAMS, the general manager from CAMS, the schools person, YIACS, which is the YMCA community mental health service, all the actors involved to talk to us as a wider group about what the current offer is, so that we can start to redesign that for children and young people. And I'm going to end on, there's the picture there of our inaugural meeting, and we're in front of the Weller Youth Centre, and that is a collaboration between the Hangleton and Knoll Project and Brighton and Hove Council. It's an asset for the joint working in the city. There's a full offer of youth work from that building. We've got children wellbeing practitioners, we've got sexual health, we've got specific SEND work. We can make this collaboration happen, and I think we can change things. It's just going to take a little while.
Thank you, Joe, Kate and Joe. That was excellent. I was enthralled. Does anyone have any questions or comments? Go ahead, Tom.
Thank you, Chair. I just want to commend all the partners involved for making sure that the voluntary sector is at the real heart of the planning, leadership, delivery of the hubs that we're seeing spring up over the city. It's been a pleasure for my organisation to be part of several of them. And I think we saw in one of Kay's slides that it was something like 3 times as many community referrals being generated compared to clinical, which is testament to that. I suppose, Chaz has heard me ask this before, but I'm going to put it to you again. What's the best vehicle through which we ask our SVLA representatives, the Sussex Voluntary Sector Leaders Alliance, to engage with the ICT leadership structure with a view to putting across the impact that we're making, but the fact that we're doing so with such limited budgets? And I've heard you describe it, Chaz, as a coalition of the willing so far. So the question is, how do we make sure that the willing remain able?
Thanks, Tom. So just to finish, the Sussex Voluntary Sector Alliance is a sort of commissioned through NHS to make sure the voice of the voluntary sector and it can act as equal partners. That's one of the principles around neighbourhood health, is the voluntary sector is an equal partner amongst local authority and NHS. So each place partnerships at Brighton Hove, we have a sort of representative of the Voluntary Sector Alliance who attends the majority of the ICT leadership group meetings. So it's one person trying to cover 3 meetings. So it has been a coalition of the willing. It is changing now, and I think that's really important that maybe Tanya might want to say a little bit more about this. The ICB are commissioning the Neighbourhood Health Alliance, and so money will start to flow, additional funds where partners work with their existing resources to achieved a lot with just existing resources. As you've seen, there will be the flow of money. So I think it's really important that the voluntary sector, through the alliance, is making sure they're represented as we start to look at ICTs as a commissioned vehicle. But the good thing is we have voluntary sector chairs who attend Sussex system leader meetings around that, and that's unique. It's not the same in East and West Sussex, so it's a unique feature of our Brighton Hove model, and we do have an active member of the team, JP, I think you know well, who's also representing voluntary sector. So, yeah, but I did wonder whether, so we've got Steve, who's sort of chair of our health and care partnership around neighbourhood health, and Steve, it might just be helpful if you heard a lot from our chairs, but maybe as the sort of lead, you might want to do a couple of reflections as well.
I was going to ask Steve to speak. I'll do that now if you don't mind, Tanya, and then I'll come to you. Go ahead, Steve.
Thank you, Chair. Thank you, Chair. So I mean, Tom has articulated in a much more authentic way everything I was going to say. But I suppose I co-chair our place-based partnership board alongside Kate Pilcher, who's the Chief Operating Officer in Sussex Community Foundation Trust, who will sort of hold the contract around the Neighbourhood Health Alliance as lead contractor. And I suppose I wanted just to reflect as co-chair of our place-based partnership that I think we got it really right in the city. I think the way that we've managed to work alongside our voluntary sector leaders who know those communities so much better than we do in statutory services, alongside primary care, has resulted in really, really impactful work around neighbourhood health, and it's turned a concept into an actual deliverable, and that's really, really to be commended. So for Joe and Kay and Joe and Adam as well, I really wanted to commend all the work you've done as that partnership on behalf of the Health and Wellbeing Board. I mean, the other thing that Tom did articulate as well was that you've done it on a shoestring. So I will leave it to my ICB colleagues to tell us how much money is going to flow over the next year or so. But there is some money coming our way, and there is some money coming through the Neighbourhood Health Alliance, and I think that will stand us in good stead for the future. So thank you.
Thank you, Steve. Tanya.
Thank you. I won't answer the last point that Steve raised, but I will sort of give a more comprehensive response. But firstly, I just wanted to say Joe, both Joes, sorry, and Chaz, thank you for the update. I think I feel quite pleased and proud having been part of the journey as well in the city, and to see the work come to fruition and to have some delivery plans as well. Really pleased and proud, and absolutely can identify with all of the examples you gave, and can also assure the board that I've been out to see the groups, and I do know that the sort of delivery elements are making a real difference for people in the city, and that's the value of neighbourhood working. And I know Joe's mentioned MDTs have been around forever, but I think for the first time we have lots of different levers being pulled at the same time, which is enabling statutory bodies and community to work much closer together. And just to touch on Steve's point about the Neighbourhood Alliance, it is a sort of a group of starting with NHS providers that have come together, but obviously also includes the Hospice Alliance and the VCSE Alliance, and working alongside local authorities. Within that delegated function through the Neighbourhood Alliance, there will be funding coming through to neighbourhoods, and that's finally being agreed through contracts with the ICB, and that shall start to flow quite soon. So I do think we're in a really good position to ensure some of the work that has started here are part of the decision making about how we sustain this and scale this for the future. I just wanted to say well done and thank you.
Thank you, Tanya. Go ahead, just.
Thank you. I think just echoing Tanya's words, absolutely appreciate all the work that's going on by everybody across the city on this. The difference it's making in neighbourhoods through the voluntary sector is immense. So thank you. Sorry, I've got my one on, but I'm facing the wrong way, I'm so I'll look this way. So it's appreciative of these people over here. The bit that I just wanted to ask though, are there any other barriers that sort of remain that you think us as a board, we here could help unlock?
I think we sort of touched on this. There's a sort of immediate urgency to try and reduce pressure on our hospital system. That sort of left shift is that sort of, but there's a risk that we lose sight of that prevention piece. And the reason we wanted to spend a bit of time bringing the work in a bit of detail to this board is that this board will have a responsibility for a neighbourhood health plan. We don't want to replicate what's done at the system level, at an alliance level, but where we can really add value is to make sure as a board that we really, through our work, focus on how do we do that piece where we're looking at prevention, looking at how do we sort of change that sort of a last approach to actually saying how can we really improve population health, and I think some of the examples, especially in those areas with highest health inequalities in the city, where we can have some real impact. So we wanted to bring this so that as we now, through our board development session, start to think about, one, what are the population health priorities that we as a board want to set for the city, and then how do we set those population health priorities with that sort of neighbourhood health sort of lens on, where we're sort of really driving that sort of prevention agenda. So, and how then, you know, do we come together at place-based level as partners and really use that experience that, you know, actually, how can we take that coalition of the willing and keep building that momentum? So how can we use our collective assets to really support that prevention? So yeah, and we talked to me in the board development sessions around want to be more deliberate as a board. So, and actually, I mean, you know, one of the next papers we're going to talk about having some meetings where we're looking more strategically, so we can have some of those discussions around what can we do as a place-based partnership. So how do we complement what's being done by the NHS at an alliance level, at a place-based level, and really focus? I think that's the opportunity for this board, so around neighbourhood health.
Go ahead, Adam. Thank you, Jess.
Just to support Chaz in that, if we can develop a shared vision and shared outcomes that we can measure, that's where how you turn all our individual siloed organisations into one. And at the moment we've got it quite top-down, reduce hospital admissions, but it's up to us to come up with what we want to do.
Thanks, Adam. Yeah, go ahead, Joe.
Just to say, I think that Chaz has said that about the opportunity, an example of that is how we think about adult social care. Steve and his team have really leaned into it. We've talked about a stratified GPs list, but actually the next step will be looking at the adult social care wait list and bringing those individuals to that MDT. That's beginning to happen. Then you genuinely see that real energy as we look at the priorities of all the partners together, and the strength of the voluntary sector that can be brought to bear to that, but also the strengths of all the statutory partners pulling together around, so that it isn't owned and sitting with just one people. And the final point is, Chaz hasn't said it, but I think we need a massive thank you to him. He's led this work from the beginning, and very self-effacing, but actually that support and that role of place is integral to neighbourhood health being a success. So the more that we can strengthen that role, the health and the wellbeing board, and the role of place within this, the more successful I think integrated communities teams can be.
Amazing. Thank you, Joe. Thank you, Kate, and thank you, Joe. We've got a couple of things we need to do, and then I'll move on with everyone's permission. But I just want to say thank you so much. That was really interesting, and it's got two things I love: bottom-up working and numbers. So I've got hundreds of questions, but I won't ask them now. I will move on. First thing we need to do is to make sure I've got the right thing here. Note the context and specific health and wellbeing board responsibilities for the neighbourhood health and development locally via integrated community teams. So does the board agree to note that? Amazing, thank you. And secondly, I think more importantly, does the board agree to endorse the free integrated community team leadership group delivery plans as presented? Agreed. Thank you. Thank you so much. I have forgotten that people need breaks, so what I'm going to do now is 5 minutes. Is that fair enough? 10 minutes. And we'll meet back here at 6:30, and then we will continue. And thank you. And let Chaz present item 9, which is the Better Care Fund March 26 to 27 plan and call for performance 25 to 26. So take that away, Chaz, and thank you.
Thank you. I will be really concise. This is not probably going to be quite as exciting as integrated community teams. So, as the board knows, the board has responsibility for the Better Care Fund plan. So the papers set out our performance for the end of 25-26, and then our plan for 26-27. So we need you to sign off on the end of year performance report for last year and approve our plan for this year. So I've literally just sort of put the kind of headlines from the report into some slides just to help us go through it quickly. So firstly, for the end of year performance report, just to confirm to the board that we did meet all of the national conditions associated with the grant around the jointly agreed plan, section 75 agreement, and so we met all the national conditions. There are 3 performance metrics that we have to set sort of stretch targets for. We missed 2 of our performance metrics and met 1 of them. So the board will remember when we came earlier in the year, our plan for last year was only given conditional approval on the basis that our metric targets weren't ambitious enough. So in quarter 3 and quarter 4, we had to adjust our metrics targets to be slightly more ambitious to get final sign-off from NHS England, which I think made it even harder to meet some of those metric targets. So the first one that we didn't meet was the emergency admissions for people over 65 years of age. So our average over the year, a month over the year, was 310 admissions per 100,000 of the population, which is 5% higher than our metric target. We've talked a lot in the previous presentation around our work around trying to do ICTs to try and reduce avoidable admissions through a more proactive care approach, and that remains our strategy for meeting that target. So the next metric was delayed discharge performance. So again, we missed this target. We were 3.6% below our metric target for the year, and 2.9 days for where we didn't discharge someone on their discharge ready date. It was 2.9 days above that planned target. Again, it was a very particularly difficult winter this year for our acute hospital, and I think that showed through in quarters 3 and 4 in terms of those were quite high discharge delays. So where we did meet our performance target was on our residential care admissions. So we set a target of 252 admissions for the year, and we actually only admitted 248 people into residential care. So we met that target in terms of being able to better support people to remain independent in the community. In terms of the end of year report and our finances, so I can confirm to the board that we spent 100% of the grant, and we met all the conditions around the minimum contribution to adult social care in terms of the financial plan for last year. So that's the end of year report. So the second part of the report just talks about the planning for our plan for 26-27. So there was a national framework that gets sent to health and wellbeing boards and health and care partnerships, setting out the expectations for the Better Care Fund. So key to that in that planning framework was a recognition that 26-27 is like an interim year, so that around how the Better Care Fund will evolve to support neighbourhood health. So it's only a single year plan, recognising that actually Better Care Fund will be being reformed and will be being aligned to neighbourhood health as we go through to 27-28. So, but the framework continued the focus on ICBs and local authorities, joint planning around integrated care, especially for people with complex needs. So again, they wanted plans to recognise that this is a transition year and to be thinking and identifying how plans align with local work around neighbourhood health. but they recognised that it was important that there was no disruption to existing critical services within the Better Care Fund. And they emphasised the importance that local plans looked at reducing discharge delays and avoid admissions, and they're particularly around looking at capacity and demand for intermediate care within Better Care Fund plans. So in terms of how we responded, so we appended our narrative plan to the papers. The plans emphasise how we were strengthening neighbourhood health services, and I think some of the things we talked about in the last presentation are supported through our Better Care Fund already. There was a strong focus in the plan around work to improve population health and reduce health inequalities and access to local services. The work around continuing to improve integration across partners through the Better Care Fund, and then there was a focus on how we were looking to reduce demand on our acute services, how we're going to assess and ensure access to intermediate care, around value for money, and then the plan covered our local governance arrangements to support Better Care Fund. So we had to set performance metrics for the year, so they're the same metrics as last year. So around discharge delay, we looked at increase. So from where we're at 84.2%, a very small increase to 84.4% in terms of people discharged on their discharge ready day, and to reduce the average delay from 11.5 to 9 days around our discharge work. Non-elective admissions, so the overall aim of the plan was to be 1% lower than current performance. And then for our residential care metric, 592 admissions per 100,000, which we set to align with our peers. So we get peer data, so we set that at line with our peers. So those are the metric targets for the year. So our finance plan, we did see a small increase in the overall finance for the Better Care Fund. So total value of just over 44 million, with an 11 million spend on minimum spend on adult social care. So the plan sets out how an expenditure plan, and I think, Giles, we weren't able to print out the Excel spreadsheets, but they're available if we emailed round, which has the detailed expenditure plan on it. So.
Yeah, it's not possible to pack Excel sheets with our committee software, but they were circulated by email to all members in advance of the meeting, so members have had sight of them in advance of this.
Thanks, Giles. And those spreadsheets you can see line by line the allocation of the grant to each of the individual schemes. So final slide, just to confirm that the plan has been developed collaboratively between the local authority, NHS and our voluntary sector partners. Our plan meets national planning framework, so local goals for reducing emergency emissions, targets for reducing delayed discharges, and reductions in demand for long-term residential and nursing placements, and improvements to reablement. Plan is aligned with wider strategies, so we made sure it aligns with ICB 5-year strategic commissioning plan that was published earlier this year, and is aligned to our local neighbourhood health priorities. So ahead of coming to this board, the plan has been signed off by CEOs, both local authority and ICB level, and by chief finance officers. We have received confirmation from NHSE saying that they've approved the plan, and we will now turn that into, so to pull the budget, we have to have a Section 75 agreement, technical part, and we have to September to put that Section 75 agreement in place, which we're working on now. So we're asking the Health and Wellbeing Board to approve the plan for 26-27.
Thank you, Chair. Unless anyone has any burning desire to comment on this, I'll move straight forward to the procedural stuff. That's okay? Cool. So Chaz has just presented the report. So does the board agree to sign off the BCF end of year performance report for 25-26? Agree. And secondly, does the board agree to approve the BCF plan for 26-27? Agreed. That's done. Thank you, Chaz. So now we move on to item 11 on the agenda, which is the final item, and it is HWB Development Workshop Outcomes and Next Steps. And I will now hand over to Giles, who will present about this. Thank you, Giles.
Thank you. So this is following on from the March workshop, which many of you attended, facilitated by Steve Bedser, who at the time was our LGA associate. And this is around Health and Wellbeing Board development. So the board has been keen to develop itself for a number of months, wanting to improve its effectiveness, wanting to better use the really quite revolutionary local population health data, including health counts that we've now got access to. Recognising that we've got our joint local health and wellbeing strategies from 2018 and much has changed since then, and it really does need a refresh. And recognising also that health and wellbeing boards are going to be doing quite different jobs in the future, and the health bill that was recently put before Parliament starts to outline some of that increased role in neighbourhood health. So a bunch of development needs, which were discussed at the March workshop. Steve Bedser from the LGA brought, I think, loads of knowledge of good practice around the country. And the LGA, we had the LGA helping us with development a number of years ago, and they were very hand-holdy and tell us where you want to improve and we'll help you. And this time round, we know what best practice looks like. We've seen best practice. You are not necessarily it, but here are the ways that you can improve. So we've looked at the conversations at the workshop, and the next few slides, I think, just kind of capture what we think was agreed. So firstly, I think there's been a recognition for many years that health and wellbeing boards are constituted as council committees and therefore formally have to meet in public as we are today as a committee meeting. That's absolutely required to do the statutory duty of the board, and that has to continue. I think at the workshop what members reflected was that that's often not the best way to do a strategic partnership development work. And going forward, the board should look at lots of different ways of meeting more informally, in addition to its formal meetings. In practice, that's going to mean fewer formal meetings. What do we need to do to fulfil our statutory responsibilities? And more informal workshops, sessions with members. Also reflected was the notion that historically we've been kind of quite council-centric, with the chairs always a councillor, deputy chairs traditionally been a councillor, and a feeling that we should have a deputy chair who came from the voluntary and community sector, and particularly from our ICTs, who are sort of increasingly central, as we just heard. So a proposal that we look forward to appointing a deputy chair who represents VCS and who represents the ICTs. Thinking sort of more broadly about board membership, that there was, I think, consensus that we ought to invite the integrated community team chairs to join the board as the board develops its sort of new role in neighbourhood health. Also a feeling that it was really important to capture local political leadership in terms of not only what we've got at the moment, which is Councillor Alexander as a cabinet member for adult social care and public health, but also in future years to look to have the cabinet member for children's services invited to the board to reflect the importance of always thinking about younger people. And we currently have blue light services who are full members of the board and are required to come to every meeting. There was a feeling that in the future that might make more sense if there were standing invites for those organisations to come to meetings where they thought they could actually contribute, and they weren't required to come to everything just because they were members. So a bit more flexibility around our blue light partners. And finally, to refresh our joint health and wellbeing strategy, which, as I say, is a 2018 to 2030 strategy. It's very out of date. We've got new data. And the other thing I think that Steve Bedser was very clear on is we need to focus on priorities rather than trying to do everything through a strategy. So those are what we picked out as kind of what we thought was consensus from the first workshop meeting. Because the Health and Wellbeing Board is constituted as a council committee, you formally speaking, you don't get to make those decisions yourself. But if the board endorses that direction of travel, then what we'll do is we'll go away and we'll talk to council colleagues and we'll try and get them sorted for the board. I think that was it for my presentation. Really happy to take questions.
Does anyone have any questions for Charles about this? I'll start with Caroline, then Jess.
It's not largely a question, so I was involved in those meetings. That's a really good summary and outcomes, I think. The bit that I just wonder if is missing, the council holds some quite key contracts with the voluntary sector as lead partners. So there's the mental health, information advice, carers, older people. What's the other?
The advice one?
Yeah.
Social prescribing.
Social prescribing. And I just wonder if the organisations who hold those contracts should have a role, if not in every meeting, but if any of those subjects are being discussed, because they hold the information from all the other providers that are within those contracts, and also the conversations with their commissioners. And so they've got a good overall view on each of those areas of the work.
So are you thinking about rotating people in and out depending on the subject?
If it was a subject, they don't necessarily need to be a member of the board, but if there's one of those topics being discussed, the lead provider for that partnership contract was invited in, then they would be able to give a good overview from the service users, the other organisations in the partnerships and their conversations with the commissioners.
Sorry, so I think the workshop we did in March was kind of modelled on that a little bit, in that we brought in a bunch of people who weren't actually members of the board, but who we thought it was really important to get in the room. And I think one of the advantages of working less formally is it's just much easier to invite people in on the basis of they'd be really good for this meeting, or they've expressed interest in it. So yes, I think that's inherent to a more flexible working environment that gets away a little bit from the everything must be done at council committee.
Thanks, Karen. Thanks, Charles. Jessica.
Thank you, and thanks for that. And I absolutely concur with what you said. That sort of resonates with what I think I heard at the workshops and what was fed back. The bit that I was just going to ask is, what's your thinking in terms of how we start to develop those priorities? Because that was a really clear message I came away with, that we need to have a really small number of critical priorities that we absolutely focus on. And I think how we're going to go about identifying those and working that through will be really helpful to understand.
Yeah, absolutely. So we've got another workshop planned. We were hoping to deliver it this summer, but unfortunately it's just not been possible in terms of diary commitments. So that's going to be early October. That's going to be with Steve Bedser again, because he brings a wealth of knowledge. And that's going to be focused on how we develop a very small number of priorities that the board can then drive.
Amazing. Thanks, Jess. Thanks, Charles. Does anyone else have any comments or questions? Or, I guess you're all part of the work, so it would be strange if you did. Thanks, Charles. So just two things remain to do. So Does the board agree to note the work to date on board development? Thank you. And does the board agree to endorse the board development recommendations detailed in the report, which was in your packs? Amazing. Thank you. With that, I'll call the meeting to a close. Thank you, everybody. Really appreciate your time and your contributions, and I hope you have a lovely evening.
Meeting in this role because it's an elected role for the voluntary sector, so from the next meeting there'll be a different rep. Hopefully Tom will be staying, but I won't be here.
Oh, I'm sorry about that.
I'd just like to say I've really enjoyed being on the board and I've learned a lot, and I hope
You should have told me, Caroline. I would have name checked you at the start as well.
Came in last minute, but
thank you, Caroline.
Thank you.
Good luck. Okay, cheerio, everybody. Thank you.